pulmonary hypertension. This also was addressed. Pulmonary hypertension is one of the major problems in outcomes. I will come back to this. And here what is really important is the relationship between pulmonary and systemic resistance, and there is a fine balance on how do you influence one and the other. And you have to imagine, if your pulmonary flow is very high, your systemic flow will be lower, and your heart needs to pump way more to deliver the same oxygen demand to the peripheral system. The unrepaired defect, and we have seen this in the previous lecture too, you see you really want to avoid fluid overload, you want to avoid increase of FiO2, decrease of CO2, because this decreases the pulmonary vascular resistance, and then it overflows again into the pulmonary. For the repaired defect, there can be arrhythmias. Many children who had cardiac surgery have problems with arrhythmias, and that is to be considered when you anesthetize them even after repair. So the AV canal is actually pretty common in Down syndrome, associated with Down syndrome frequently. And here you have a free communication before in the four chambers, and that actually, in general, they can be very well balanced, and we have done children, they just go to anesthesia very smoothly, and again, the severity being so extreme that it's difficult to say this is the rule to follow. But once they are repaired, they actually can have residual defects because they had a common valve, and now they have two separate. It says the same thing again. Okay, it's the same thing again. I can't manipulate my screen. So I just wanted to show that, as was mentioned before, I can only repeat it, the complexity is very different. I'm just continue talking. And there are several scenarios. Oh, I'm going to shorten it. So, okay, good. Okay, so I'm a little off my lecture here. Coarctation of the aorta is one of the obstruction, and these children are actually dependent on their continuous PDA, and they may come to you, probably, I don't know, in a hospital, but if you have a baby like this, they're dependent on the PDA, and they normally should come on a prostaglandin infusion to keep the PDA open. That's the only way that blood goes to this system. And so you see, when you look at these lesions, they are so particular that when asked to give just one advice, it's nearly impossible. So it's now coming to the mixed lesion, the cyanotic lesions, as you call them. The first procedure, most of the time that's performed for these procedures, is a BT shunt. So you may encounter children that are partially repaired, that have a BT shunt. The BT shunt actually brings blood from the subclavian artery, normally to the pulmonary artery. And this is a very sensitive shunt. These children are dependent on very good flow, on very good volume. If you dry, if your child is hypovolemic, the shunt can clot, and that's basically a disaster. It can really be death on the table. You want to keep the circulation the saturation between 75 and 85. Everything over 85 means your pulmonary vascular resistance is going to decrease, and you will have an overflow of pulmonary overcirculation with the risk of congestive heart failure. And if you lose suddenly your SRO2 during the procedure, that means that most likely your shunt is occluded. And the cath lab is the next step. It's very difficult to get these children back once they go this road. TOF is another mixed lesion where it is really important to have a balance between pulmonary and systemic resistance. And when you see children, sometimes you have older children that have not been repaired. They actually, in order to control the systemic resistance, they go in the squatter position. They increase the systemic resistance like this, and so more blood is allowed to go into the pulmonary system. Same here. Today these TOF kits get repaired very early, so you should probably not see them in a common hospital. When they are repaired, they are prone to arrhythmias and often have an ICD or a pacer implanted. Some of them get a first step repair, and some have actually a BT shunt before final repair. These kits can go into what everybody knows about Tet spells, and that's actually a vicious cycle, and it's important to break it, and these children need then 100% oxygen. They need a bolus of volume. If this happens during anesthesia, you need to deepen the anesthesia. You need to phenylephrine is the medication of choice to increase systemic vascular resistance, and beta blocker is sometimes used for the infundibular spasm. And ECMO would be the last resort in these children if you cannot break the Tet spell. The hypoplastic left heart, this is a really complicated lesion, and had basically, these children died years ago before the Norwood procedure was actually, I think it was in the late 50s, you may correct me there, and from then on the survival improved. These are children that should not be done in a peripheral hospital. They go through several stages of palliation, and as you mentioned before already, they depend on passive flow from the venous return, so they're very much preload dependent. The data that I will show in a second will show you that they should really not be done in a normal hospital. The repaired heart, though, you have to remember, may have no normal cardiac function, may have residual shunts, poor myocardial function, may be prone to arrhythmia, and present with pulmonary hypertension, severe and regurgitant lesions. And here again you see the hemodynamic consequences, whether it's on the right side or the left side, and the goals you should basically look for when you do anesthesia. Long consequences, and the scary part are the 4 topics that were discussed earlier, and I just briefly mention them again: pulmonary hypertension, congestive heart failure, cyanosis, and arrhythmias. Pulmonary hypertension to the left to right shunt increases the blood flow in the lungs and ultimately increases the pulmonary resistance, and it can give you vicious circle, and you have a cardiac arrest at the end. And so the treatment of a pulmonary crisis is, of course, 100% oxygen, hyperventilate to induce respiratory alkalosis. Nitric oxide would be the first choice of the treatment, and support the cardiac output, and again, at the end, CPR and possibly ECMO, which you probably would not have in a peripheral hospital, and that's one reason why these children should not be treated in a general hospital. So here you can see this is a study that looked at pulmonary hypertension for non-cardiac surgery, and they found, you can see children with pulmonary hypertension, they have a much higher risk of not only suffering cardiac arrest but also dying under anesthesia. Congestive heart failure was already discussed in the previous lecture. Anesthesia management for heart failure is actually not very different from the adult management, and I'm not going to insist there. Cyanosis due to right to left shunt or to inadequate pulmonary blood flow, or the mixture of oxygen and deoxygenated blood into the systemic circulation. And as was mentioned, it causes a lot of other organ damages. And if your hematocrit is over 65, your oxygen delivery will be compromised. And so that is a discussion that needs to happen also with the pediatric cardiologist, whether phlebotomy should be done or not. The hyperviscosity signs for hyperviscosity actually are headache, dizziness, fatigue, and these are signs to look out for in these children. And of course, important here, avoid dehydration. Thrombocytopenia is often present, and they're used to hyperventilate in order to deliver more oxygen to their system. And so when you ventilate them, you need higher tidal volumes to ventilate them correctly. Also, your end-tidal CO2 will not be correct for these children, so you really have to have a low threshold to do a blood gas and check this. Same for your saturation. In cyanotic children, the SiO2 under 80 is not very reliable, so you need to check this with blood gas. IV access is often difficult, and again, I only can repeat, fluids are really important. These children should not be dehydrated. Arrhythmia, what's important here is actually when these children come with devices, with implanted devices, they need to be interrogated normally the day of. We have a policy that any pacer or ICD device needs to be interrogated within 24 hours prior to anesthesia. And there is a practice advisory that was published in Anesthesiologist in 2011 that gives kind of a guidance on how to proceed. Some children are on amiodarone, and that should not, as all the other medication, should not be discontinued. So again, just a little summary for intraoperative considerations: pulse oximeter, A-line, and also electric activities. On the EKG, do not guarantee perfusion. They may be there, so you always have to check. You always also want to touch the child, look at your capillary refill, look at things that we have actually lost to look at over time because we have so many monitors. But I think they are important. For your pacers, always have a backup in case your pacer has a problem, and think about what are my hemodynamic goals and ventilatory goals for the specific child with that specific lesion that I have there. And there is, again, the discussion. So I wanted to bring up just two recent publications that have tried to stratify the risk for non-cardiac surgery. One is they have looked over 6 weeks at all the children that they anesthetized, 2,200 children. 100 of them had congenital heart disease. And they looked at how can we they stratify? They put, according to the cardiac lesion, they decided on low risk, moderate risk, and high risk, similar what was shown below. And then once the cardiac lesion was actually defined as low risk, moderate, and high, then came the other additional components that. So a patient less than 1 year, we know they are more complicated even when they're healthy, have more problems, additional comorbidity, and so if all these is present from a low risk, you go to moderate risk. Same on the next, from moderate risk, you can go to high risk. So they actually divided, they found out that 23 children were classified at low risk, 66 moderate, and 11 as high risk. And these high risk kids, they decided these will be done only by pediatric cardiac anesthesiologists. And I think it's important to start thinking about this as we have more and more patients coming with corrected hearts to us, to think about it, how do I organize my team? I cannot force somebody who has, I cannot force all the CHD patients on the cardiac pediatric anesthesiologists. There are not enough of them.
2 minutes.
So
remaining 2 minutes, Professor.
2 minutes? Okay, so I'm just going to talk about the second study that was published, and that's a retrospect analysis of the National Data Bank for the from the American College of Surgeons, the NESQ, where all data are entered from children's hospital, children under 18 years who come for non-cardiac surgery and have congenital heart disease. And they this data bank look at tremendous variables, 129 different variables. So what they did, they took out of this group major CHD and severe CHD patient. And you see there how they classified major is repaired with residual hemodynamic abnormalities. For example, a TOF with wide open pulmonary insufficiency or hypoplastic heart syndrome, including stage 1 repair, and severe is uncorrected pulmonary hypertension, ventricular dysfunction requiring medications, or children listed for heart transplant. So they took 4,375 kids with major and severe CHD in order to find what are the points, what are the relevant points that can tell us ahead of time these kids are a special group. And then they used close to 3,000 children to validate this score, this cohort and this score. So here are the different variables they looked at the beginning: age group, ASA, type of procedure, prematurity, type of procedure, was it emergent or elective, surgical specialties, craniosynostosis or whatever surgery there is, all the surgical fields, preoperative respiratory disease, preoperative oxygen supplementation, were they trached, kidney disease, was there CPR preoperatively or any other surgery 30 days before, was there preoperative transfusion, and a preoperative event was defined as an event occurring between the day of hospital admission and the day of surgical surgery. So they looked at all these, and they found, out of all these, they actually found, first of all, that the incidence of mortality in the derivation cohort was 4.7%, and in the validation cohort was 4%. So very close both. And they found 8 preoperative predictors for in-hospital mortality. And they use these 8 predictors to do their logistic regression model. And these 8 are emergency procedures, severe CHD, single ventricle physiology, surgery within 30 days prior to the procedure, inotropic support, preoperative CPR, acute chronic kidney injury, and mechanical ventilation. And the interesting thing here is that they did not find that the surgery itself had any influence on mortality. That if these sick children had major surgery or if they had just a basic dental procedure, the risk was the same. That did not influence them. And I think this is a very important information, because very often we say, oh, this is just a short little procedure, why don't you do it? And this shows us that we shouldn't. So the risk stratification were then from 0 to 10. They created a score. 3 is low risk, 4 to 6 is medium risk, and over 7 is high risk. And you can see that here you have the risk stratification down there, the scores, how many risk factors you have, and you see the mortality is the red line, increases to 50% mortality if you have a score of 10. And the single ventricle children's appear to be at an increase of in-hospital mortality regardless of their functional status. If they're stable or unstable, they have a very high risk of cardiac arrest for non-cardiac surgery, and a very high risk of in-hospital mortality. So my conclusion, most children with moderate can tolerate well-managed anesthetic. And as I said before, if it's in a hospital where you used to do children, you probably may be a little more comfortable. If you don't use, then I think I would always tend towards, I'm not going to do this because I'm not comfortable and it's not safe for the child to do it. So I would be very careful and have a plan for postoperative care too. If you can't provide adequate postoperative care for these children, then it's another reason to maybe transfer them to a center where they can. Thank you very much.
Thank you very much. That was a lecture from Professor Maria Matuzak about children with congenital heart disease, corrected congenital heart disease, and children with non-corrected congenital heart disease. So the last lecture is we'll talk about enhancing surgical recovery. The speaker is Edward Lifesens. So first lecture, just to remind you, first lecture was preoperative optimization, preoperative assessment and optimization, children with congestive heart disease. And second lecture, it was combined 2 lectures. Professor Matuzak spoke about children with corrected congestive heart disease and non-corrected congestive heart disease.
Thank you very much, Dr. Ismail and Professor Maria, for excellent lectures. My question is really maybe for both of you. It's regarding where to do these patients. And you mentioned both that they should be done, the high-risk ones should be done in specialized pediatric centers. Is this related to the presence of a pediatric ICU, or is it the pediatric cardiac anesthetist? Because we do face this problem here in Kuwait, that we don't actually have sick kids hospital that have specialized pediatric cardiac anesthetist. But we have some general hospitals that have pediatric ICU. For example, in Adan, we have pediatric ICU, and so we have the backup. But does that mean that we can do the high-risk patients in Adan hospital? And if we don't actually have the option to send them to a pediatric anesthetist. So what's the best option for these patients?
If I may answer this, actually, because Dr. Maria, I think it's easier way in Texas than it is with our situation here. It's, the issue is not having just the ICU per se. It's the knowledge and the skill, both. I mean, the knowledge comes in different people with their expertise of their backgrounds and training, as well as the skills of taking care of such patient. pediatric cardiac anesthesia is, how you say it, a rare commodity. I think worldwide. I mean, it's not just here in Kuwait. I mean, in the States, you have these highly specialized children's hospital, which we don't have actually here. So the question comes, the importance of having a children's hospital, per se. And, what children's hospital will have in between its wings, all specialties. I mean, these patients can be actually, from their categorization, the risk stratification that was actually mentioned by Dr. Maria, and I had it earlier from a different study. A patient who's at one stage is a low risk can actually go into a high risk on this, on the table. He can change his stratification on the same day of the surgery. So, for those patients, I mean, if you don't have the pediatric cardiologist available on site or easily accessible to answer some of the questions, because he would be answering more than anything else, whether through a knowledge base or doing an investigation for you, echo or something, and then the anesthetist who's doing the work there during the surgery, and the intensivist who's later on caring for the patient post-operatively. So you need them all. I mean, if you don't have them, these patients, especially the high risk or the moderate risk, intermediate risk patients, you can lose them just in a few minutes. Simply in few minutes, they can, just die. And it will be difficult to retrieve them. So the issue is not just having a pediatric intensive care unit. So PICU will care for these patients post-operatively. NICU will care for them post-operatively. But what about? I will just mention a simple example. Dr. Salah is not here. I don't know, he left, Dr. Salah Taqi. Just a couple of days ago, a patient was born with tracheoesophageal fistula, esophageal atresia, and these patients, as some of us know, Dr. Maria knows, you have to operate them so quickly. I mean, you can't just wait. They have, a fistula from the lungs going to the guts. And the patient, sorry? They are so difficult. So you have to operate, and the patient had a large defect, and he had severe pulmonary hypertension. So even children, when they come, they don't read the book. So they don't come with one thing, with one entity. They can have combination of things. So this patient was born in a private hospital, which is even, with all due respect, would be less than a district hospital level of care. And, was requested to be transferred to the only pediatric surgical, which is in Messina, but it was difficult. So it was transferred to another local district hospital, which is the KOC in that situation, where we have a pediatric surgeon. And they, people worked on actually having some compromise, because the patient needs to be done. And it's easy to lose the patient. Patient did very well, had the surgery and everything, is almost being for extubation today. But things can go wrong, okay? We sometimes work with what we have, but it's not ideal in this part of the world. At least, if I may say, and everybody knows it as a fact when it comes to pediatrics, it's less than optimal. Because most of all, we lack children's hospital, where these patients should be in. Because anything can go wrong, simple stuff can go wrong, and patient is lost. So I know it's a long answer, but it's my sad feeling not to have a children's hospital. It's especially when you go and train and work in children's hospital, and then you come back and there is no children's hospital. Dr. Maria, if you want to add.
Yeah, so I just have a question myself. Where are the children's operated, the cardiac lesion? You have a chest hospital, or? And
we have the chest hospital, and they do the pediatric surgery there, the cardiac pediatric surgery, and we have Ibn Sina that does the pediatric surgery for other specialties, but things like dental procedures, endoscopies, we tend to do them and emergencies, yes, we do them in general hospitals, like Adan Hospital, Amir Hospital, and Jahra. So we do deal with these patients, but we do have often these problems that when we have the high-risk patient, we don't have the facility to send them to the Ibn Sina, because you don't have a dental list, do you, in Ibn Sina? So they have to be done in Adan Hospital. So we ended up having the experience in dealing with these patients, but the question is, I mean, ideally we should have a sick kids hospital, but we don't. What do we do meanwhile? How can we improve our facilities? Shall we get a pediatric cardiologist in our hospital? Sorry, yes. Pediatric anesthetist, yeah. We don't have people that are subspecialized, but we have people that have the experience in dealing with very young children.
I mean, at least I think there should be, the contact should be established with the treating. I mean, if they have cardiac disease, they have a pediatric cardiologist, right, following them. So that would be the first step. I mean, ideally, yes, there should be a place where the children are taken care of. Because, I mean, it's not only, it's a team, it's the team that's important. It's not one ICU or one pediatric anesthesiologist. Even if you would transplant that pediatric anesthesiologist in an environment where he normally doesn't work, that's already some risk factor in itself. Even though he has the skills, he would have the skills in another, in his facility, he may be lost in another facility, you know. So I think it's a team approach, and maybe that's something to think about, how, as there are more and more of these patients, there's something to think about how you change the infrastructure here to make that happen.
In the meantime, while waiting for the children's hospital to be established, would it be a good idea to create a mobile anesthetic unit to anesthetize patients which are high-risk cardiac patients for non-cardiac surgery? Because I work in an orthopedic hospital and we are facing a pediatric patient with the complex cardiac lesions. I do believe the spine unit, for example, they do that in Kuwait. They have a mobile spine unit which they go and operate different places. Why don't we have a mobile anesthetic unit which go and operate on this high-risk cardiac patients in non-cardiac hospitals?
Yeah, it's a good idea. Why not?
Thank you.
It's
very
an
much.
excellent. Yeah, and you need, it's like you are calling for an ECMO team that will be equivalent
Yes.
to that, you know? But, you know, it's...
You need to remember, you need a 24/7 coverage then, and that's not easy to put in place, you know, and so.
As I said, there's already a mobile, for example, vascular unit in Kuwait, which they go operate for vascular surgery. We have a mobile spine unit, which they go operate in spine cases in different hospitals in Kuwait. So I think at the meantime, while waiting for the children's hospital to be established, I think it's workable.
I mean, it remains a good idea. It's an excellent idea. It's just to implement. Just maybe if no further question, just a last wording again. Like Dr. Maria is saying, there is no harm to ask for help. It's a teamwork. Lots of these patients, again, our patients with congenital heart disease who are operated or not operated, they are surviving through, you know, older ages. So when they can present at any moment for whatever reason, elective or emergency, most importantly, those for emergency situation. I mean, when you face such a patient, please ask. Try to find out, you know, a source where can actually be more informative regarding the condition of the patient and how to approach him. And that will be actually very, you know, valuable for the outcome per se. So asking for help always should be useful. Doctora.
Can I just add, because we are thinking of the surgeons, but we have to think more on the anesthesia and the nursing and the anesthesia technician and the post-operative care. This is not a